Hello, good evening, everyone. I'm very sorry for the delay for having experienced some technical problems. May we now start our webinar. Here are some reminders. We are using Cisco WebEx Event Center for this webinar. If you're having trouble joining, you can log out the session and rejoin through the link sent to you by WebEx or by entering the meeting room number 571-347-781 and password is Maryland123. We remind attendees that your mics are muted throughout the meeting, but you can chat your thoughts to us through the chat tab. And for questions, you can type them in the Q&A tab. Tonight's speaker is Dr. Smisha Agarwal. She is an associate in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Since 2012, she has been working with Johns Hopkins Global mHealth Initiative to provide technical support for monitoring and evaluation to a number of mHealth projects focused on maternal and child health. Some of these projects include MAMA in Bangladesh, Mom Connect in South Africa, CSTUC in Malawi, and a multi-country nutrition program by GSMA. She has worked with the WHO mHealth Technical Evidence Review Group to develop a number of tools to improve and evidence on digital health mHealth interventions. Before we proceed with Dr. Smisha's lecture, may we now call on Dr. Garrett Mel to deliver a lecture. Hello, Dr. Garrett.
Hi, Cha. Can you hear me?
Yes, I can hear you.
Oh, terrific. Thanks. This is Garrett Mel from WHO, and I just wanted to thank AHIN for allowing us to present to AHIN on the work that Smisha and colleagues that are part of the mHealth Technical and Evidence Review Group have been doing. The mHealth Evidence and Reporting and Assessment checklist that Smisha will be providing an overview of was really developed to reflect, to address the challenge that we were seeing in the literature of not enough articles that were of sufficient quality in describing the mHealth or digital intervention or the research and impact of those results. And because WHO is invested in developing guidance for countries around what investments they should make in digital health, we wanted to ensure that those who were publishing on research were doing it at a sufficient level of quality that we would be able to then incorporate that into the development of guidelines. And so after a considerable amount of work in developing a checklist and validating the checklist, we have the pleasure of having a published checklist that follows the Equator Network's guidelines around publishing. And Smisha has been very kind enough to both lead us through the development of this checklist as well as being able to present to AHIN today. So I truly hope that those of you who are in the AHIN network and who are contributing to research in this space can leverage the mERA checklist and the guidelines around reporting so that research in your countries is not only improved in quality, but also that we're able to then make use of it for guidelines, which WHO is currently working on. And I'll also note that this mERA checklist is part of a document that will be released within a month's time that is focused on monitoring and evaluation of digital strategies. And that document will be available, and we will organize with AHIN another session on the entire document there. But without further ado, I'd like to hand over to Smisha, and thanks very much to AHIN and the Secretariat for allowing us to present. Thank you.
To see. Are you able to see my slides?
Yes, we can see your slides, Dr. Smisha. Thank you.
Okay, great. Okay, so like Garrett said, the mHealth evidence reporting and assessment checklist. I'm trying to see. Okay, there you go. The checklist was developed in response to the rapid proliferation of digital health solutions and the limited evidence on their effectiveness. So there was a call for better evidence about the effectiveness of these digital interventions. Just to give you an example, since 2011 alone, there have been over 1,700 publications in peer review that are focused on digital health. However, as we conduct reviews to summarize evidence, we find that the quality of the studies or the reporting of the studies is often not sufficient for us to be able to come to any conclusions. So a little bit more of the background on mERA. Over the last year, we've done a few reviews on the role of digital health solutions in improving healthcare outcomes or in improving intermediate outcomes. And one of them has been, what is the role of digital health solutions in increased performance of healthcare workers? And you'll see that it ends with the review revealed that there are very few formal outcome evaluations of mHealth in low-income countries. That continues on for other areas as well. For HIV treatment and prevention, the conclusion is that there was a lack of evidence around the use of mHealth tools to address the needs of key populations. Similarly, for non-communicable diseases, support for elderly patients, again, paucity of research, chronic disease management, and so on. So that is what resulted in sort of the development and the thinking around the mHealth evidence reporting and assessment checklist. The purpose is to, like Garrett briefly spoke about, is to help authors, and it may be peer-reviewed authors, but also program implementers who are reporting on their digital health projects, to help them, it's to be used by them to improve the reporting of their mHealth interventions, improve transparency in reporting so that you can critically assess the quality of any mHealth research. And we hope that through standardized quality of reporting, there is an indirect effect on the quality of evidence itself. So what this checklist does, it's a set of 16 items that identifies the minimum set of information that is needed to define the content, which is what is the intervention, the context, where is it being implemented, and the technical features, how it was implemented. What it does not do is it does not aim to support design or implementation of studies on digital health. So it may not be used as a way to define how one would conduct a digital health study. So the emphasis is on reporting. There are other guidelines that serve a similar purpose, though not in the area of mHealth. So some of you may have used previously CONSORT, which are guidelines that are used for reporting of randomized trials, or TREND, which is used for non-randomized trials. There's COREC for qualitative research, STROBE for observational studies, TIDEAR, the one in the middle, which is closest to mERA, and mERA has actually used TIDEAR to inform some of its items. It talks about better reporting of interventions, and SQUIRE, and there is about a list of over 160 checklists specific to different fields that are all hosted on the Equator network that Garrett mentioned, which is essentially a web space that's hosted by the BMJ, and it contains all the guidelines, study design specific, as well as content area specific, substantive area specific. I'll go into the rigorous process that was undertaken to develop mERA, and then I'll start going into the list, the 16 items. So the development of mERA was 3 years of interdisciplinary and multi-institutional collaborations led by the WHO, mTurk, and it started in late 2011 when the WHO convened a panel of experts from Johns Hopkins Global mHealth Initiative to recommend an approach to develop these guidelines. And after the initial approach was proposed, it was discussed at a 3-day meeting in Montreux with 18 experts from across different sectors and organizations and countries. The result of that meeting was that a quality of information task force was set up, comprising of 5 members. They pilot tested the checklist on a number of peer-reviewed and gray literature to come to an agreement on final list of items. And then again, this list was applied to 10 English language peer-reviewed articles and gray literature articles, and the definitions were tweaked. And finally, it was applied to 3 independent topic areas by 3 different research groups, one at Johns Hopkins, the another one led by Mark Mitchell at Harvard University, another one led by Kelly Lengel at FHI, and the one at Johns Hopkins led by Alan LeBreek. So the idea was to take the checklist and apply it to 3 different types of literature. A health systems focused literature where we picked management of stockouts, a provider focused literature where we picked promotion of provider adherence to protocols, and the client focused literature, which we picked promotion of adolescent sexual and reproductive health. So again, you see the sort of iterative process of applying and tweaking the checklist to ensure that it applies to a broad range of literature, essentially. So finally, the checklist comprises of 16 items, which we consider the core mERA checklist. And like I previously mentioned, it has items on the content, the context, and the technical aspects of the digital health intervention. But in addition to the core mERA checklist, there's also a 29-item methodology checklist, which I'll not go into in very much detail in today's session, but the methodology checklist is available online on BMJ's website, the Equator Network. The idea behind the methodology checklist was the recognition that a lot of digital health innovations are being conducted by individuals who are working at the cross-section of the technology or innovation space and may not be familiar with research reporting recommendations. And so we wanted to make a checklist that was easily accessible by people who may not be quite as familiar with other methodology checklists. However, we do recommend that ideally the 16-item checklist, so the core mERA checklist, is used in conjunction with a study design appropriate checklist. So like I previously went over some of the lists, a consort for randomized trials or scope for observational studies. And the mERA checklist, the mERA methodology checklist is designed to be study design agnostic. So it does not recognize the study design. It's a little bit more generic, and it allows a little bit more flexibility in reporting, since a variety of study designs are being currently employed in the digital health space. So I will start going over the items of the checklist. It starts with the infrastructure, which is that in any reporting on digital health, one should clearly present the availability of infrastructure that is needed to support the technology. The idea behind this is that that we want to ensure that the intervention can be transplanted into another area, so that there should be that level of transparency to help the reader to discern whether the intervention or what kind of infrastructure is required for the intervention to work well. So, for example, a number of studies may report a percentage of people who have access to a mobile phone or who have network coverage. And we recommend that if such statistics are reported, they should be reported for the area where the intervention is being implemented. So the second item is the technology platform. It is essentially helping, it's asking to report why did you choose a certain hardware or software, and describe that hardware and software in sufficient detail to allow replication of the work. If one used open source software, what modifications were made to the software. The third item is interoperability or health information systems context. And that is to describe how, if at all, the mHealth strategy connects with the national or the regional health information system. So we emphasize that it is important to understand how the digital strategy adds to the existing workflows or improves on existing processes or complements existing programs. So a description of interoperability, even if it has not been thought about very well, can help us understand whether the activity or the digital health activity is a limited scale pilot project or a strategy that can be scaled up nationally or to other parts possibly. The fourth item is intervention delivery, which is asking to elaborate the mode, frequency, intensity of the mHealth intervention. So part of the reason for requiring this item is that best practices in what the ideal mode of communication or timing or duration of communication are emerging, and we recognize that there are certain times in certain populations that are more optimal than others for an IVR call or for an SMS to be sent for the client to be responsive. So reporting that will help generate more evidence on what these best practices are. So details such as what is the frequency of engaging the client, how many messages are sent, what time of the day are important to report. What is the content of the intervention? That's the fifth item. So here we're really asking for the content source to be reported. And if there is existing content that was adapted, then what kind of adaptations were made? If new content was developed, then what standards were used to, was the new content based on, and what the development process entailed. The sixth item is usability testing, which is essentially focused around any formative research that was done to develop the system. So the definition and recruitment of end users that were involved in conducting the formative research is important to understand, and it should be clearly explained. And also the depth and breadth of the formative work that was undertaken to engage the end users in developing the system. The seventh item is any user feedback that was developed, and we recognize that at least in peer-reviewed literature, a number of pilot studies have independent papers that report user feedback, which may include user opinions about the content or the user interface, perceptions about usability, access, connectivity, and any other elements of the mHealth program. So we recommend that, I think, if there are space restrictions in reporting, that every document about the digital intervention refers back to where this user feedback testing was conducted. So the eighth item is access of individual participants. And This is to encourage reporting of whether the intervention considered what some of the access issues might have been. Challenges to access could be related to socioeconomic status, maybe geographical location, education, literacy. We do know that often it is not women who are the primary owners of cell phones, so there may be gender norms or gender issues that may limit access, and so on. So reporting it will help the audience understand if these access issues were considered. A basic presentation of the cost assessment. So there are currently guidelines called the chair's statement, which is a 24-item checklist that guides researchers for reporting any economic evaluation. So we do recommend that as far as possible that the chair's guidelines are used, but we also recognize that that there is insufficient knowledge or reporting on the costs of several digital health interventions, and even if no cost effectiveness or cost utility analysis done, programs may have access to basic cost information, and we recommend that that information is presented. So the 10th item is adoption input or program entry. And this may mean two different things. So for digital health programs which have healthcare workers at the center of the program or the primary users, there may be training that may have been conducted for these healthcare workers, and that's what adoption inputs would mean. And program entry is if it is a large-scale sort of mass communication digital health program, how do you inform your clients about the existence of the program? So what kind of advertisements or outreach work was done to ensure that the program is able to reach its audience? The 11th item is limitations for delivery at scale. And we understand that pilot studies can be implemented well, often, and everything tends to work. However, things at scale don't usually work quite as well. So in view of the challenges in translating findings from these pilot studies to large-scale implementations, we recommend that any limiting factors that authors may be aware of at the onset for delivery at scale are described. The 12th item is contextual adaptability. And that basically is around have the authors describe the steps that are necessary to adapt the mHealth intervention to other use cases. So for example, if a piece of software is hard-coded, adaptability could be limited or costly or time-consuming. So specifying these limitations to contextual adaptability of the system that is being reported can help clarify whether the system being tested can be considered for other users as well. And contextual adaptability is also for different language or helping understand a different population context. The 13th item is replicability. So presenting adequate technical and content detail to support the replicability of the program. And this recommendation is to encourage authors to provide details of the development of a replicable process or the development of processes that can be deployed in a consistent manner. So it may include things like the software source code, workflow, dashboards, flowcharts of algorithms, and presenting that kind of information can be really valuable to the community, to the digital health community. And again, we recognize that there are usually space restrictions to present that level of detail. However, we recommend that as far as possible, there's a link provided where such information can be accessed, or it's presented in appendices in peer-reviewed literature. The 14th item is around data security and confidentiality protocols. So this recommendation is for a brief explanation of the hardware, software, and procedural steps that are taken to minimize the risk of data loss or data capture, and to ensure that the data are secure, especially since a lot of mHealth or digital health interventions are targeting vulnerable populations. So we do want to think about data security protocols up front. The 15th item is compliance with national guidelines or regulatory statutes, where the recommendation is to describe whether any national guidelines or other sources of information that are coming from maybe a national or international body have been used to populate the system content. So this may mean if a system is providing SMS-based advice to women, does the information follow evidence-informed practices that are nationally recommended, as an example. And the final item is whether the intervention was delivered as planned, the fidelity of the intervention. So this is really thinking about whether the mHealth program's adherence to the intended original deployment plan was assessed, and if it was assessed, what the results of that assessment were. So that is the list of all the 16 items. Like I said earlier, that this information is available at the link provided here. We very much expect this checklist to represent a set of evolving criteria, just as the field is evolving. And we would expect that any user feedback may result in future revisions. So I think we also have Alan Lebrique on the call. Maybe Alan, if you have any other thoughts to share.
Thanks, Misha. You've done a fantastic job, and I really want to reiterate how much work went into this, both from our group, but really a global consortium of people who've been both excited by the prospects of digital health, as well as frustrated by some of the limitations that we as a community have faced in trying to articulate the growing evidence base around these innovations. I think anybody who's in the audience who has tried to build literature review or synthesis has faced the frustration of going through the published literature only to find that they have to discard a large amount of what's been reported because of inadequate content or coverage of the actual intervention, the mode of delivery, the intensity or exposures, and all these other facets that have been highlighted so eloquently by my colleague. One point that Misha made earlier, and I think it's very important to understand and maybe think about the potential of this tool, not just as a reporting tool, but as a tool as we move forward in implementations, to be thinking about whether or not we've thought through these various aspects of the development of our innovations, and have we given due thought to how we will report at the end of the research or at the end of the implementation, how we went about doing some of these various development phases of our innovation. And so as we sort of go forth prospectively, having such a checklist in hand can only help us to plan and think about how we would answer these questions at the tail end of the work. So we're really hopeful that more and more groups begin to adopt this. And just as a pragmatic guideline, for those of you who are sort of in the middle of writing up your results or working with groups to disseminate or publish your work, go through the checklist, try as best as you can to incorporate answers to these main questions, and then in the introduction or at the conclusion of the document, make sure you state that this article has been reported consistently with the criteria, the mERA criteria with the citation. So that's really all I have to say about that, and I'm really glad that we have such a good attendance this morning. And if there's any questions, I'm sure we'd be happy to try and respond to them.
Dear everyone, we are now open for questions. You may type your questions at the Q&A tab. If you cannot locate the Q&A panel, you may write your questions at the chat tab. Thank you. We now have a question. Since this involves digital reporting, how do we manage data security?
Misha, I don't think we can hear you if you're speaking.
Hi, no, do you want to take that question now?
Oh, so let me just answer Gilbert's question first, and then I'll come to that one. I think one of the things we were trying to get at is these aren't necessarily best practices for implementation, because those are actually covered in a variety of different documents, including standards and guidelines. And as Dr. Mel mentioned a minute ago, there's a couple of tools that have been developed by the same group at WHO. One of them is the MAPS toolkit, the mHealth Assessment and Planning for Scale toolkit, that's available on the WHO HRP website. And another one that's just coming out is the M&E for Digital Health workbook, and that's also going to be coming available in the next few months. But in terms of security standards, although they are useful to know about, they weren't necessarily an impediment to being able to report on the level of evidence or the type of exposure or the type of intervention. When we think about which studies we can compare to one another in terms of their exposure and the type of interventions that they provide to participants, that was one criteria we thought about for quite some time, and at different times it was raised, but ultimately when trying to be parsimonious and select the most critical criteria that really reflected our ability to synthesize and extrapolate common findings, that didn't survive. But the checklist itself isn't necessarily a scoring methodology or someone asks you how does it work. I think it's like all the other checklists in the Equator network. The goal is to ensure to the best of your ability that the items that are in the checklist have been somewhat touched upon in your reporting. Or if you can't report on them, let's say you have not done an economic analysis, then stating that as a part of your reporting is going to be important.
Hello, any more input from the panelists?
So I suppose one way in which we have tried to use the mERA checklist as a scoring system is during the initial stages when we were piloting it, we applied it to a variety of literature, and we scored with zeros and ones whether the specific item was described in a peer-reviewed article. And so you'll see one of those applications in a peer-reviewed manuscript, and that's likely to be published in the next month or so. And that's probably one way in which it could be used for scoring, but that's definitely not the intended use. It's very much like Alan described.
All right, thank you, Dr. Snesha. We have another question from one of our attendees. It reads, how is it helpful in the compliance with the national guidelines, especially in our country, the Philippines?
So I think the question was, how does it comply with national guidelines in developing countries? So, again,
sorry, the question is, does this tool help to improve compliance with national guidelines? But I don't think the tool is intended for that use.
Yeah, so the tool is not intended to improve compliance with national guidelines. It is, however, it does, however, require you to report compliance of your content, of your procedures with national guidelines. So if you have not used whatever national guidelines are as part of your digital intervention, this tool helps you report it in a transparent way so that others can assess what you're doing and understand what you're doing and why you made the decisions you did.
If I can maybe if we take a quick step back, one of the things that as we were developing this checklist, one of the earliest applications of the checklist to two bodies of literature, as Smisha described a minute ago, really gave us an appreciation for the need of this tool. Because as we went through and scoured the literature to identify published and gray literature around a particular topic area, let's say the use of digital technologies to prevent stockouts. One of the things that we found was that there was extremely variable reporting of this content. Some authors would spend a lot of time talking about the digital intervention, but very little about the evaluation of that technology. Other authors would go into great depth about the evaluation, but then just say, oh, and we use text messages to remind people we send text messages to inform about stockouts. But what was the frequency? What was the exposure? What was the incentive structure to encourage people to send messaging? How frequently were the messages sent? All of that information was lacking. So this extremely variable quality makes it quite difficult at the end of the day to understand whether you are comparing apples and oranges or apples to apples.
All right, thank you for that input, Dr. Allen. We have another question. It reads, where have been this tool used and what are the outcomes generated using this tool? Examples. You're asking for examples.
So, like I mentioned briefly in my presentation, that so far the tool was used in the pilot testing stages, where it was applied to 3 areas of literature: stockouts, improving provider adherence, and sexual and reproductive health, adolescent sexual and reproductive health. So the guidelines have only been published last month, and this is our attempt to start disseminating it. And so I think the hope is that it will be this community that will start using the tool more. And we are already beginning to see some publications that are coming out that have used the tool in their reporting. That more so, I think, and that's the reason for us to present to this audience today, really.
All right, thank you, Dr. Smisha. Any more questions from the audience? If you have questions, you may type them in the chat box if you can't locate the Q&A tab. If there are no more questions, maybe we can close the session. If you have additional questions that you would like to raise, you may send us an email and we'll forward them to the speakers for today. Any more last points that you would like to reiterate, Dr. Smisha?
Well, I guess this is just a primer of the tool, but if you do use the checklist, and we hope that you do, you can please feel free to get in touch with us if you have questions or if you have any feedback for us. Alan and Garrett, do you have any other thoughts?
This is Garrett. I just wanted to thank AHAN and the organizers and also the participants on the line for the interesting and useful questions. We'll be very interested to see people's use of the mERA checklist, and we hope that the evidence reporting that comes out in the literature is strengthened so that we can ensure that guidelines that are being developed at WHO can we can be very confident in the recommendations that we make for investments in countries. So thanks to everyone on the call.
Thank you.
All right, thank you everyone. Please answer the survey we'll be sending after this session so you can get the materials of this session. Thank you so much to our speakers, Dr. Smisha, Dr. Garrett, and Dr. Allen. Thank you everyone.
Thanks, Cha.